it's my pleasure to be here doing this demo. And this demo, I will share this session with Professor Jeremy Beitler. Beitler?
Yes, unfortunately, yes.
No, it's not unfortunately, come on. And we divide this presentation in two different parts. The initial part, I will present you the different variables. And then Jeremy will present you some case reports, and our idea is to stimulate you to answer all questions according to the basics that I will present to you now. Okay? So let's start. So our demo is entitled Individualizing Ventilator Management in ARDS. So my name is Patricia Rocco. I'm a full professor at Federal University of Rio de Janeiro in Brazil. And this is our challenge, to ventilate a patient with ARDS. Imagine to ventilate a patient where we have areas of consolidation, areas of alveolar collapse, small airway collapse, or normal areas. It's a huge challenge. Because if we decide to use 20 to 30 centimeters of water, okay, we may open the alveolar collapse and even the small airway collapse, but we may overdistend one part of the lung, and we may induce a huge inflammatory process. So how to deal with it? This is a paper that I published with Paolo Pelosi and other collaborators in 2021. It's entitled Personalized Mechanical Ventilation in ARDS. And the rationale is to regulate the ventilatory parameters based on close monitoring of target physiologic variables, intervention response, and individual integrated goals. So my target, my objective now is to present to you the tidal volume, the stat contributors of VILI, as well as the dynamic contributors. So the tidal volume, plateau pressure, driving pressure, and PEEP. Okay, but it's also important. I told yesterday about the importance of measuring the dynamic variables to induce VILI, because everybody thought that we have only to focus on tidal volume, PEEP, driving pressure, and plateau pressure. That's it. No, we have to focus on respiratory rate. We have to focus on inspiratory time. And the combination of all these factors may lead to the measurement of the mechanical power. Mechanical power is another variable that we have to be computed at the bedside. Okay, so tidal volume. Tidal volume is around 4 to 6 milliliters per kilo predicted body weight. But now, with this nice group, we are also measuring the end expiratory lung volume. And this is important because we are dealing with moderate, severe ARDS, and it's not easy. We are dealing with the baby lung, and who cares? We have to understand that if you have a severe damage, the baby lung reduced, and probably we have to focus on which is the tidal volume that we have to measure. And one interesting strategy is to normalize by end expiratory lung volume. Okay, this is a strategy. And what about the driving and the plateau pressure? Plateau pressure is easy. We need only a finger to occlude the airways at the end inspiration. So it's not difficult to be measured at bedside. And the driving pressure as well is the plateau minus PEEP. Okay, for most patients, driving pressure should be target below 13 And although driving pressure may help individualize tidal volume and PEEP settings, it's not clear whether driving pressure is superior to other methods to titrate the PEEP. And PEEP titration is a huge challenge. If you asked me, how do you titrate your PEEP on the daily practice? Depending on the ICU. Because if you are able to have, for instance, a measurement of transpulmonary pressure using esophageal catheter, it's okay. It's a very good measurement. But if you don't, PEEP table, probably. But whenever possible, clinicians should aim to keep plateau pressure lower than 27. Okay, let's move forward. The transpulmonary pressure. You can copy, you can photograph, because these are important formula to be used at the bedside when you have to compute the transpulmonary pressure. Many people ask me how to compute transpulmonary pressure. Okay, with esophageal pressure. Who cares? You need the airway pressure. You need the esophageal pressure. And with esophageal pressure, you understand what's going on in your chest wall. And this is a very important point, since Jeremy will present us a case of obesity, a case of change in the chest wall. So we need to evaluate the transpulmonary pressure. And we also need to evaluate what's going on in the lung. Because sometimes the chest wall is completely changed because of the abdominal surgery, because of the compression, different causes. And here we have the different formula, the static and the elastance of respiratory system, lung, and chest wall. Okay. Different formula to evaluate the PEEP titration. We may evaluate using the PEEP table. Okay. PEEP and FiO2 were titrated to achieve oxygen saturation between 88 and 92. This is a very important issue, and I talked about the rest is the best yesterday. And this is a very important point, because everybody, oh, it's a 93. I'm afraid I will increase the FiO2. Please don't do so. Respect the physiology of the curve of the hemoglobin. And so from 88 is 92, it's good. PEEP setting according to the driving pressure. PEEP setting according to the static elastance. And the transpulmonary pressure. Okay, the other point is the mechanical power. The mechanical power, oh, this formula is a little bit strange. No, it's not strange. 0.098 is only for conversion to joules per minute. Times tidal volume, times respiratory rate. This is another point. When you have a lung damage with ARDS, you have to focus on respiratory rate. Peak inspiratory pressure minus driving pressure divided by 2. And in ARDS, we have to respect the mechanical power. Now I would like to invite Jeremy Beitler. He's from the Columbia Respiratory Critical Care Trials Group from the Columbia University, and he will present us the different clinical trials. And according to my presentation, you will answer immediately. And if you have any doubt, Jeremy can answer. Go ahead.
Thank you so much, Patricia. Okay, so we have three cases that we're going to go through. Thank you. And these are meant to be interactive, so I would appreciate the interaction as we do this. So the first case is a 43-year-old patient with HIV/AIDS and cachexia, who presents with fever, cough, and worsening dyspnea. I'm sure you couldn't have guessed that in this talk. For 7 days with a chest film that's demonstrated there. Patients intubated for acute hypoxemic respiratory failure, really ARDS. Initially set with a tidal volume of 6 cc's per kilo, predicted body weight, on which there's a plateau pressure of 32. A PEEP is 12 with no auto PEEP. The respiratory rate is 27 with slight acidemia and slight hypercapnia. A PO2 of 71 and a FiO2 of 60% for a P to F ratio of 118. The patient is paralyzed. And the clinical team attempted to prone the patient, but hemodynamically, the patient became bradycardic and hypotensive and started to desaturate. So they decided to leave the patient supine to avoid causing harm. So I guess the first thing to think about is sort of how you feel about the ventilator settings that the patient is currently on. What principles would you think about in making any changes? And then what types of changes might you think about making initially? So if anybody wants to, is brave enough to opine, please.
The PaCO2 is quite low for that kind of sickness. So in order to make it more stable, probably a reduction of the peak pressure would help.
Yeah, exactly. So you're saying with a PCO2 of only 48, it's not terrible hypercapnia. So there's potentially room to be less aggressive with the tidal ventilatory support. And, if you're going to adjust tidal volume or respiratory rate, the data that are out there would suggest that tidal volume would be what you would reduce first, which would lower airway pressures. So exactly as this gentleman said, tidal overdistension is likely present. Sort of, if you wanted to put a number to that, we had a plateau pressure of 32, a total PEEP of 12 because we said there was no auto PEEP. So the airway driving pressure is 20 centimeters of water, which is extremely high. As a frame of reference, if you think about transpulmonary driving pressure, I can tell you, having personally done this, if you swallow an esophageal balloon catheter and breathe all the way to total lung capacity, your pleural pressure will get to somewhere between minus 20 to minus 25. So if you think about what your own or my own transpulmonary pressure is, and this is backed up by what Jerry Mead showed half a century ago, in healthy lean adults, at total lung capacity, at the maximum amount you could normally insufflate the lung in life, you achieve a transpulmonary pressure of around 20 to 25. So a driving pressure of 20, while granted reflects both the lungs and the chest wall, is quite high. A driving transpulmonary pressure, at FRC, at resting end expiratory volume in healthy individuals, transpulmonary pressure is right around 0. So our driving pressure from resting end expiration to total lung capacity in a healthy individual is about 20 to 25. So this is essentially maximally stretching the lungs, so extremely high, even though the plateau pressure is not that high. And so one of the first lessons, which is old news from a couple decades ago, is that shortly after the Ards and ARMA trial was published, they looked at the relationship between airway plateau pressure and mortality in ArdsNet. In the 6 versus 12 cc per kilo tidal volume trial, and found that there was no threshold effect. So I think this sort of dogma in our clinical practice of, plateau pressure of 30 or less, it's just that. It's dogma not backed up by data. And so we shouldn't be falsely reassured that a plateau pressure in this patient of around 30 is safe, especially because airway driving pressure is so high. This is just the story of driving pressure that I mentioned, and most people in the community, I think, refer to a driving pressure of somewhere between 12 to 15 as probably the upper limit. That's based in part on this analysis from one of your colleagues in Brazil. You're probably on this too. But similar papers using other data sets have suggested similarly that a driving pressure of somewhere between 12 to 15 is probably in the safer range, and certainly the curve seems to pick up quite substantially afterwards. So as we mentioned, would you change tidal volume or PEEP? The answer there is tidal volume. And the rationale for that, as Patricia was saying, is because of the difference between static and dynamic stress and strain. So for a given maximal amount of stretch of the lung, you can either start at a high PEEP and just stretch it a little bit, or you can start at a low PEEP and stretch it a lot. And when you start at that low PEEP and stretch it a lot, that more increase in dynamic stress and dynamic strain is far more injurious. And so this is something that Pradi and colleagues showed in an animal model. It's also been shown in ex vivo human lung models when you're stretching the tissue. So this is, I think, fairly or quite accepted across the community that if the choice is to, if you're stuck with a certain amount of peak stress, if you will, to try to minimize the amount of dynamic stress that's there. So we recognize the high driving pressure. We recognize that there was certainly room for more permissive hypercapnia, and maybe if you wanted to go up on the respiratory rate. So we decreased the tidal volume in 1 cc per kilo increments down to about 4. Increased the respiratory rate because interval blood gas was looking worse, and we ended up with a plateau pressure of 28. So our new driving pressure is 16, which is certainly better than 20, but still relatively high. There's our repeat blood gas showing more hypercapnia, more acidemia, but still, I think, in a tolerable range, especially for this patient who's paralyzed where you don't need to worry about dysynchrony. So now that our airway driving pressure is lower, how do we feel about this patient? Would we leave them here and say, okay, we're at a driving pressure of 16, we moved on tidal volume, that's good enough? Or would anybody take additional steps?
Yeah, I've got a question. You've decreased the driving pressure in the tidal volumes, but you've increased the respiratory rate. So how do you know if you've actually improved things or made things worse? Because you're giving less volume, but more often.
That's a great question too. So Patricia's certainly right that curious in your perspective on this that both frequency and magnitude matter. But I think the data, both from clinical trials and from even ex vivo animal models, suggest between the two, it's the magnitude is the more injurious. And so in this case, yes, we went up a little bit on the respiratory rate, I think. But the sort of ratio that's out there is 1 cc per kilo per 4 breaths per minute is what people suggest might be a magical number from cohort studies. But I think I'm struck by, I guess, two things. One is the ArdsNet ARMA experience, where they asked this exact question, right? Because they had relatively comparable total minute ventilation, and it was, do you want high tidal volumes or high respiratory rate? So you could think of ARMA as a high respiratory rate versus low respiratory rate trial, and it was the high respiratory rate that was superior, that had better survival. And then in ex vivo models as well, you can stretch with a higher frequency and experience less injury as long as the magnitude is less. So it's not that it's not important, and that's the extreme case where like ECMO could take care of both of those things. But between the two, it prioritize magnitude. And you had some.
Yeah, just one explanation for you. If you prefer to change some variables, tidal volume is better than respiratory rate. So there is a paper published by Luciano Gattinoni and his group showing which is the variable that induces more damage. So, for instance, in this case, his therapy is perfect because he has to choose something, and he decides to reduce the tidal volume. When you reduce the tidal volume, you reduce the amount of mechanical power in the baby lung, because you are starting ventilating this baby lung. So, but he has to do something, because he needs to focus on the PHA. So he decided to increase the respiratory rate, even though respiratory rate may increase the mechanical power and induce more damage. We know that the first parameter to be modified is the tidal volume.
Sorry, what I wanted to add is that looking at these lines now, the PaO2 didn't change. Of course, we did quite a lot in trying to ventilate with lower tidal volume, higher rate. The PaO2 did not change. It fall actually from 71 to 70. So this is no progress.
I don't know if I would say it's no progress. I would say that We made great progress on mechanics and when I think of supporting the ventilator-dependent patient with ARDS, it's my sort of two goals are, one, to maintain gas exchange consistent with life. That's it, just consistent with not dying. But then two, to try to minimize iatrogenic injury from the mechanical support of the ventilator. So I think we've made progress because we haven't contributed to, if the patient were now desaturating and had a PO2 of 45, then of course this isn't the right thing. But since that was relatively constant and we improved the mechanics, I think this is a step forward. So sort of where would we go from here? Just in the interest of time. The driving pressure, as I mentioned, is better with that reduction in tidal volume, but it's still high. And I dropped a couple of clues early on in the case. This is a younger gentleman with AIDS and cachexia. So studies came back showing that the patient had pneumocystis pneumonia, PCP, which for those of you who have encountered these patients, they tend to have a very profibrotic process in the lungs and very, very stiff lungs sort of mechanically. And so in this patient, they had high driving pressure despite trying to optimize tidal volume and respiratory rate and a strategy of permissive hypercapnia. You could try to scale back the respiratory rate and push the hypercapnia further if you feel comfortable doing so. But the lesson here is that there's still evidence of overdistension, and we feel like we've sort of done what we can on the tidal volume. So where would we go from here? Well, then you would think about PEEP titration. And this is a little bit paradoxical because now this is a patient with relatively high FiO2 requirements, but where you have data telling you that the patient is likely overdistended. And so I'm not saying that you would empirically lower PEEP, but you should try and see how the mechanics change, right? And different patients might respond differently. But I can tell you, I've been surprised, even as somebody who uses esophageal manometry, that sometimes mechanics do improve and you are actually overdistending the patient, especially patients like this that have what feels clinically like a more fibrotic lung. So if you're ventilating a patient with idiopathic pulmonary fibrosis, for instance, if you try to go up on PEEP at all, no matter how hypoxemic they are, very likely mechanics will just be incredibly deranged. You'll encounter very, very high airway pressures. So we tried lowering the PEEP. In doing so, the plateau pressure disproportionately decreased. And so you can see we lowered the PEEP by increments of 2, from 12 to 10 to 8. But the plateau pressure decreased by even more than that, signaling that you were overdistending the patient. It went from 28 to 25 to 22. And so our final driving pressure that we landed on was 14, which is now potentially in a safer range. And so we feel good about that. But now the problem is, okay, since we went down on our PEEP and we lowered our airway pressures, now the patient is starting to desaturate a little bit. And so what would we do for there? Would you favor going back up on either PEEP or tidal volume, or what kind of strategy might you take? And assuming the patient can't be prone, because obviously if they could be prone, you would try that. So any thoughts? Yeah, so you would certainly try proning. You would do the simple things that we would all do, even if we're not thinking about it now, like turn up the FiO2. Not a complicated maneuver. But the other thing that I do want to bring up, which I would argue there's evidence for, is to consider other adjunctive therapies. So proning has mechanical benefits in addition to obviously the potential effects on gas exchange, and it's probably the mechanical benefits that influence survival. But I think this is a case where you could say there are data to support using things like inhaled pulmonary vasodilators. And the reason you're using them and the data you would cite is the same consideration you would have when you're debating whether a patient would go on ECMO. You realize that in and of itself, the therapy is just a way to augment gas exchange. Which is all that ECMO really is, right? ECMO is just, okay, I can do gas exchange, like got that taken care of. And that allows you to facilitate more protective mechanical ventilation on the lung. So you can scale back mechanical support further so it's more maximally protective. So Eolia, the Ellen Combs ECMO trial is really a trial of more protective ventilation. And so if you think about pulmonary vasodilators in that way, if my choice is I could go up on the PEEP and I could exacerbate overdistension, or I could reach for a pulmonary vasodilator and fix the gas exchange that way, the more protective thing, I would argue, based on studies like Eolia, is probably to reach for the adjunctive therapy that in and of itself doesn't have a benefit except for improving gas exchange. But that's what you need to maintain your more protective ventilator settings. So any questions or comments about that case?
I have only one comment before you're moving forward, okay? Remember that these patients present a fibrotic process. And many people think that fibrosis need to have a higher PEEP. Please don't think so. His strategy was perfect because he reduced the PEEP level. Because if you have lower compliance and you increase PEEP, you will be unable to homogenize this lung. So in this case, be gentle with this lung, not overstretch it. So this is one important point because many of you deal with COVID or fibrotic lung process, regardless of the etiology. And you have to pay attention with the PEEP and with the tidal volume. Go ahead, please, your question.
I was wondering if you had any data to support or maybe abstain from a high-risk evacuating bronchoscopy in these difficult oxygenate patients. Is there any reason to try bronchoscopy or maybe to,
You wanted to have the...
or is it too high risk?
It's yours, but I can answer.
Go ahead. Sure.
The point is that I usually perform bronchoscopy to analyze the diagnosis and to understand how is the behavior of the alveoli. If I don't have, I have to do the bronchoscopy. There's no problem. But the point is that these patients was so severe. And if you don't have the diagnosis, but he has, he knows that this is mycoplasma, no?
Pneumocystis, yeah.
Pneumocystis. Oh, that's it. It's not mycoplasma, it's pneumocystis. So he knows how to treat it. So, in my opinion, no bronchoscopy. But if you don't have the diagnosis, the patient, evolved with a worse prognosis, things like that, I usually perform bronchoscopy in order to know the diagnosis, the situation, the degree of the inflammatory process, yes.
Yeah, no, I agree completely. I think if there were concern of, if the radiograph suggested, plugging of a central airway, then, of course, you'd potentially try to do it for therapeutic reasons. But otherwise, if you have the diagnosis, we tend not to necessarily do it either. So this next case, the first part, maybe I'll go over quickly because we're running out of time. So it's another younger patient, this time with morbid obesity, as you can see by the extensive amount of soft tissue on the x-ray, who has the flu. The tidal volume, again, is 6, plateau pressure 30. Those numbers should look familiar. This patient, though, has a PEEP of 24 on those settings. There's our respiratory rate, our gas exchange again. And in this case, as you may have encountered, the patient's body habitus is such that it precludes proning because it's not safe to turn them on the bed. So what do you think about these ventilator settings? Well, sorry, in the interest of time, I think that they're probably safe, even though our plateau pressure is comparable to the other patient. And the difference in this case is that we have a low airway driving pressure, right? 32 minus 24 is 8 for our driving pressure. We also have evidence of pretty good gas exchange, right? Only a FiO2 of 50%, PCO2 that's pretty low without a very aggressive respiratory rate. So low dead space fraction, low ventilatory ratio. And clinically, as you see the patient and you're looking at the film, and based on the mechanics, you have very strong suspicion that the chest wall is a major contributor to what's going on here. So whereas in the other patient, we were concerned about overdistension, in this patient, we're actually quite confident that even on a PEEP of 24, that there is not overdistension. And so I think people sometimes get to that initial point, and often where I encounter the patient then is, well, what do I do now? How do I actually get the patient off the ventilator? Sure, I can leave the PEEP at 24, but how do I wean the support from there? And so I wanted to just very briefly talk about a couple strategies for doing that. One is, remember that their body habitus was the same thing before they got respiratory failure and got intubated. So they had a mechanism for accommodating that physiology ahead of time. And you're taking away some of that compensation by deeply sedating the patient, or if you're paralyzing the patient. And so facilitating spontaneous negative pressure ventilation, spontaneous breathing, is potentially the very important first step. And with those mechanics, I would feel comfortable doing that even on a PEEP of 24. Next thing is when you start weaning PEEP, people often get fixated on this, I need to keep the tidal volume at 6 cc's per kilo. And so they wean PEEP with a constant tidal volume. And what you're doing then is you're just gradually deflating the lung, right? Because now you're fixing the tidal volume, lowering the PEEP, and you're dropping them below FRC. You're just deflating the lung as you drop PEEP. And that makes no sense. So, I think as a first safe evidence-based thing you could do would be to liberalize the tidal volume at least up to 8 cc's per kilo, provided that the driving pressure doesn't shoot way up. That would suggest overdistension, which is unlikely to do. A third strategy, this is sort of evidence-based, sort of not, would be to think about other ways to try to mimic what's happening in normal respiratory physiology. One would be to think about periodic sigh breaths that you can program on the ventilator. A number of groups, including Tommaso Mari's, has demonstrated that even just a sigh breath 2 times a minute help to facilitate preservation of end expiratory lung volume, so it helps to maintain recruitment, even if you're otherwise scaling back on ventilator support. And there was recently a JAMA trial, and I think it was trauma patients, surgical patients, that suggested potentially a benefit to periodic sighs as well. And then the fourth thing is, if you've done all those things, you consider liberalizing tidal volume further. This is where it becomes more of a judgment call of how the patient's doing. If their organ failures have resolved, I think it's not unreasonable to keep pushing the tidal volume higher as long as you're comfortable with the other mechanics, the driving pressure, in an attempt to facilitate getting the patient off the ventilator. And I think we're probably out of time. I don't know if we should go through this third one. Give me a look. Any questions about that case? That patient? Because they're, so if you put in a esophageal balloon catheter, which I intentionally left out because not everybody has it, you would encounter very, very high pleural pressures. And so when in our EP-Vent 2 trial, for instance, the patient with the highest pleural pressure was at my site, had a pleural pressure of 35. So that patient was on a PEEP of 35. It was one very similar to the patient I described. And he did just fine, wide awake, hemodynamically stable, put him on pressure support, and did a strategy like this to wean him off the ventilator. But it's because that PEEP is mostly just pushing against the chest wall that it would be safe. If you or I had a PEEP of 24, we would probably arrest right away. So it's context dependent. And as I mentioned in an earlier talk, it's very important not to, if you inherit that patient on your ICU service and they're at a PEEP of 5, it's very important not to just immediately turn the PEEP all the way up. You would want to do it stepwise because you don't know hemodynamically necessarily how they're going to respond. All right. We could do this last one really quickly, I guess, just because it's fun. So this is a patient with some sort of dysynchrony, which people love to get called to the bedside for. The classic patient is fighting the ventilator. So this is an example of breath stacking dysynchrony, which is defined as 2 machine inspiratory cycles without exhaling all the way between them, right? So we and others have shown that when you have this phenomenon, you get quite high tidal volumes. If the patient's on 6 cc per kilo tidal volume with breath stacking, they get 6 plus 6. So they're actually getting a 12 cc per kilo breath. And so with this patient, they were set at 6 cc per kilo and had a set rate of 30. They had breath stacking every 3rd breath. So that means 10 times a minute, they were getting a 12 cc per kilo tidal volume, give or take. And that's pretty darn close to what you saw in the control arm of the Ards ARMA trial. So while we don't have definitive data in clinical trials that says this is harmful, it seems quite likely from our understanding of the literature that if they're doing it often enough, 10, 15, 20 times a minute, that's quite likely to be harmful. And so this particular form of breath stacking is something called reverse triggering or entrainment. And I think oftentimes when people present this, it's hard even for me to follow, and I don't think it needs to be that way. So one of the classic clues to something being reverse triggering or entrainment is that it's a rhythm dysynchrony. It's a rhythm phenomenon. So when you're looking at the waveforms, it's really looking over time and trying to see if there's a very clear pattern. Because if it's a respiratory drive related phenomenon, if it's from the patient having high respiratory drive, oftentimes that's less rhythmic, right? We have conscious control of ventilation, it can be more sporadic. But with entrainment, the body's internal pacemaker, respiratory pacemaker, is synchronizing to what the ventilator is doing. So it's trying to match that rhythm, and it's like, and sometimes that synchrony is slightly off. Right, so the ventilator fires, and then shortly thereafter, the rhythm generating center fires, and that's what you see happening here. After this, sorry, let me first point out the repeating pattern. Right, you can see it's a stacked breath, and then 2 times where there's none, and there's actually a clue here that the patient's doing it every breath. Right, because you can see after the cycle, flow again pretty quickly comes back up to 0 before exhalation occurs. So that's the pattern that you would want to try to pick up. If you don't believe me that this is a pattern, so this is the same patient. We actually did have esophageal manometry in. And so now you can see that that second breath is clearly starting after the machine cycle. And it's clearly a forceful patient effort. You see the negative deflection and esophageal pressure there. And it's such a pattern that you can actually put ECG calibers to it, just like you're reading an ECG, an EKG. And you'll see that it's a fixed interval. So when you have this example of a firing of the patient node, if you will, that results in depolarization of the ventricle, right? So firing of respiratory rate that actually gets the full volume into the lung, there's a refractory period, just like a PVC on an EKG. And these other intervals are also fixed, but are narrower because it's effort without that broad depolarization. It's effort without the broad volume change that the lung is expecting. So you have 2 sort of sets of fixed intervals. One is when the effort actually transmits into a volume delivered, and one when it doesn't. But these are quite literally copy and paste, these are fixed intervals between each effort there. And so this is very much a rhythm, a pattern that you can pick up just by watching the waveform. So things you could do for reverse triggering or entrainment. Well, the first thing to do is, again, if this were a supraventricular tachycardia and you weren't sure what was going on, maybe you would give adenosine, right? You would block one of the 2 nodes. So you can do that on the ventilator. You can block one of the 2 nodes just by taking away the set rate on the ventilator, put them on pressure support. Then the only rhythm generating center out there is the patient. Another thing you could do is that this seems to be brought on in the context of sedation and opioids, so you would decrease those. You could think about also taking back the ventilator support just by decreasing respiratory rate. And sort of as last resorts, if you're really concerned that this is injurious, thinking about things like paralysis, or if it's less frequent, just have permissive dysynchrony, right? Presumably this happened in every ARDS trial ever done, short of the paralyzed trials, and benefits were observed in the trials where they were. So in this particular instance, we did a definitive procedure that, as you can see from the top 2 waveforms, completely eliminated the dysynchrony. And all we did was we took the respiratory rate and we turned it down. So we made sure that the rate of firing of the machine was less than the entrainment rate of the patient. And as soon as we did that, the dysynchrony went completely away, and every breath was an assisted breath. So if you think about what that happens from a Villi perspective, by changing the respiratory rate alone, we actually changed the tidal volume, right? We took away all those stacked breaths that were 12 cc's per kilo, where the only intervention we actually did was we turned down the respiratory rate. So that's an example of entrainment or reverse triggering and how at least you would work through the problem. I think, again, the first thing just being thinking about pressure support. Right. And in the interest of time, are we over? Thank you for your attention.
So thank you so much. Congratulations. Thank you for all of you to be here. It's a great audience. Jeremy?
Yeah, it was a pleasure. Thank you, everybody, for your great questions and interactions. Really appreciate it. We can hang out for a minute or two if there's any questions, but want to let everybody go because we're over. So thank you so much.